Good morning. This is Samir Mehta. I am the moderator for the session today, and welcome to the 11th session of ccclivecases.org. We have another very exciting chronic total occlusion case to show you, and before I move you on to the cardiac cath lab, let me, Samin and Anu, let me first congratulate you. I have in front of me the latest report from the New York State PCI registry, and once again Mount Sinai is right on the top, and highest volume, lowest complication rates for Samin Sharma and Dr. Kinney. Congratulations to both of you, and it's over to you, Samin. Excellent job done over the last 3 years. Huge volume increases, but most important, I think, the lowest complication rate is the one which fascinates me. Samin, take us through the case today, and what are you planning to do?
Sure, Samir, and thank you. And of course, I welcome all our viewers. Actually, I was just told this morning that we have crossed the 10,000 mark.
Congratulations.
Yes, that's a great achievement that more than 10,000 web hits have been since we started this in July, and we are in the 11th month now. And as you mentioned, that the volume and complications. Now, Sinai, we actually have received this double star. You know, double star basically means that statistically lower than statewide mortality. Now, usually every year there will be 1 or 2 centers, and about 4 or 5 physicians get this double star status. Now, what makes it real peculiar, or special I should say, for us, for Sinai, it's the first time ever a center which is number 1 in the volume and has got the double star. So that, you know, people call it that this is not a home run, this is like a grand slam. You know, Indian, either with the ball out of the park or a cricket way, it's a sixer.
Look,
and
this is wonderful, and congratulations to your entire team, and Anu, wonderful job.
Thank you. Great. Therefore, this and of course, the rest of our staff working great. Now,
Samin, I just want to also remind our viewers that the webcast as well as the archive is going live on stream, iPhone and iTouch. So if you are still traveling and not at your computer, you have that possibility of watching the transmission too. Samin, back to you.
Yeah. Great. And the other, the one more add to it, that as I said, from physician point of view, that between 3 to 5 physicians every year get the double star, and so, but never ever from one institution have been 2 physicians. So this really, as I mentioned, was great, and that led to actually Mount Sinai did a first time good publicity. They took a 1-page ad, and last Friday in New York Times. They spent little money. But having said that, the whole purpose is why we were there, and that is all this performing these complex cases with a protocol fashion and the technical excellence. And this is what we try to teach in our our monthly webcast. Now, this is our case number 11. The patient, the new exertional angina, class 2, and has a positive stress test for moderate inferior and moderate anterior ischemia. This patient actually was fine until a few weeks ago, about a month ago, then started having chest pain, and of course has a positive stress test, and has risk factor of hypertension, hyperlipidemia, smoking, asthma, and a positive family history. He has been on aspirin, torvastatin, and bronchodilators, and of course we started him on clopidogrel last time after the intervention. Now, cath was done on April 30, revealed 3 vessel disease and ejection fraction of 60%. Syntax score was 29.5. White was it's a left dominant system with left main mild diffuse, LAD complex lesion of the proximal with total of the mid, along with the big diagonal originating there. The rest of the LAD fills very slowly by collaterals, and I'll show you that angiogram. And Circ had a LPDA lesion, and RCA was a small vessel, significant lesion. So last time, patient had a stent of the LPDA. So now, Anu can take us through this particular case today, that what we have now, and you can see here. Anu?
Yeah, just if going to the LV, we always check an EDP. She was 15 this morning, and if you see, there's a little bit apical dyskinesis, but other than that, the entire anterolateral, apical, inferior, all the walls are moving, and in fact, her ejection fraction was quoted to be normal.
Also impressive calcification,
yeah,
right?
Heavy calcium of the LAD, which we can see, and as you know, it's best seen in the LV gram in the low projection, and this is what we just took a picture of the left system where we did the LPDA previous stent. That looks good. And this is right is a non-dominant, but what we saw during the last time was that despite that RCA was filling the LAD, and you see a good surface collateral as well as the septal collaterals through the RV branches through the acute marginal of the RCA. So this is a dual injection. If you see there in the mid LAD, you have almost about a 15 millimeter total occlusion. After a diagonal, so you have a bifurcating LAD, heavy calcium and total occlusion in that LAD in the mid area.
And as you saw that, I'm going to take a live picture of see, you don't see the distal LAD. It's all filled by that collateral. So it has been a long standing occlusion, lot of calcium. Actually, you don't even really see where the entry point is. But compared to the previous picture where you do a bilateral injection, you see a reconstitution of the vessel.
So, any change in the morphology of the lesion between the first case as so far as the LAD is concerned, or it's exactly the same?
It is the same. It's the when patient was here last time, and so nothing has changed.
Also, if you see, it looks like there are multiple branches, a small diag, at least couple of septals coming out at that same area, and I think like Dr. Sharma mentioned, we don't know exactly where is the entry point.
Many times you need to go to a LAO view. LAO view actually sometimes can tell you in some of these cases.
Well, many years ago we used to go LAO 90, but I bet you in a total occlusion that is going to radiate all of us.
Yes.
I know that's a 6 French based system.
This is a 7 French.
All right.
We decided that since the diag is big, if we have to end up doing a bifurcation intervention, we may need a 7 French system. Otherwise, majority of the time, we like a 6 French system.
And it's a short sheath?
Yeah, it's a long, the groin sheath is long, which we always like, which is a 45 centimeter long sheath, and that gives us a good support. And if you see, it's the LAD and the circ has the two separate, almost two separate ostia, short left main. So we went with the FCL. The C curve sits very well in the LAD, and it is a 3-5. So if you know 3-5 goes since LAD is anterior, take off with if there's two separate ostia, usually you need a shorter guide to go into the LAD and a longer guide to go into the circumflex. Circumflex always is posterior and below. You will need a longer. So since the 4 regular catheter went into the circ, you need a smaller one to get into the LAD, and now we took a 3-5 FCL and we are just in the LAD.
Okay, with that note, while we are trying to get ready, what I'm going to do is a little interesting, and about 2 weeks ago I was in the fellows course in Miami, and my task, which I have been doing actually for last 7 years now, of the guide wire selection. And but usually we get a lot of requests to send me send them the slides and so. And this time I already got over 50 people who have asked me for the slides. So I thought the best way would be that I just present the guide wires, and we'll have it available in a PDF format on our the website. Now what I'll do is, knowing that the procedure takes quite a bit of time with the total occlusion and so, I'll make it a short presentation for I'll time it for 10 minutes. So we're starting at 9:10 and I'll be done by 9:20.
So, this is exactly the lesson to have learned from last time, to give yourself a little more time for a complex case.
Exactly. And then knowing that this will be available on the webcast anyway, so that people can download those slides and so. So this is the two important, knowing that this patient is a CTO, we'll be focusing on two things, because a lot of new things are coming also. One is the guide wire, and secondly the new devices for the tough and complex CTOs. Now, basically, if you go through it, that the guide wire selection is the workhorse wire. There our most important goal is the safety and one-to-one torque. and of course it contracts well in a straightforward cases, which is about 60 to 70%. Second is the specialty wire, where it's a tortuous anatomy. So you need to make the prolapse. Sometimes you make an angulation. Their one-to-one torque. Safety comes little second, but the one-to-one torque and no tip prolapse becomes very important. And of course, we would try to see that these wires should not go into the small branches and cause the perforation. Then, in a very tough lesion, distal lesion, extra support wire. There, our goal is to have a heavy support for tortuous and distal lesions. Now, goal is in those cases, many times you cannot use them as a primary wire. You may have to use some exchange exchange length catheter or over the wire balloon to get those extra support wire, because you may not be able to make a one-to-one torque them and advance distally. And lastly, the extra stiff wires, which are for we call it a chronically stenosed or CTOs. Basically, that you go through with a different penetration wire power into these total occlusions, and that's where is that you gradually escalate from a less stiff to a higher stiffness. Reason being is that those wires can go subintimal and more importantly can cause perforation. Now this basically what I had done is, this slide actually depicts various types of wires which are available in the market. The workhorse wires with the BMW series and IQ, Cougar, and now we have kinetic wire of the Boston Scientific in that, and Cougar is of the of Medtronic, the Lewis, the run through of Terumo, and ATW with the Johnson & Johnson. Then the specialty wires, the Whisper, Balance, Pilot, and Stabilizer, and Choice and PT Graphics of Boston Scientific. Extra support wire, the Iron Man and basically Grand Slam and All Star of Boston Scientific, Abbott, and the Mailman of the Boston Scientific. And the most important to me extra support is putting two wires, buddy wire, which is not a wire, it's a buddy wire technique. And lastly, the extra stiff wires of the CrossFit, Miracle, Confianza, and now we actually have the newer Progress family of wires. Purpose there is that go through these tough lesions by increasing stiffness so that success occurs. And clearly there is a whole science behind it, that should you use a lubricated wire and when do you go to the more stiff wires, and particularly the Confianza group, which is a very thin wire like a small needle, 0.009, that you want to make it ultimate penetration of the tough cap, that you will require those Confianza and wires for this purpose. Now they basically I would say the real breakthrough in the wire technology occurred with the BMW. The BMW basically is the number one wire in the world of BMW Universal, and now the Universal 2. That whole concept basically was that bring the nitinol technology with the shaping ribbon for durability and moderate support. And this is where the whole advantage of this wire is. And overall it is said that about 38% of the wires in the world are the BMW family. And clearly that we actually have used as a workhorse wires for years and years, and of course last few years we are using run through also. But BMW remains the safest, most user friendly wire, and this was the revolution compared to our earlier generation by bringing the nitinol technology for the one-to-one torque. And of course there are many schematics of it, but then becomes Universal, Universal 2, and BMW Advance. And these all will be provided in the slide, so that I would not worry much. Then run through, Terumo run through, which actually is a very nice, same thing, hydrophilic coating, and up to the tip with a nitinol core, but distal tip is a platinum coil, and it's a silicone coating, so it's not a hydrophilic at the tip, so that prevents perforation, because we worry about any of these wires. So the Terumo actually works out both combination of your specialty wire and workhorse wire, and we are using quite a bit in majority of our cases in our cath lab. Then issue becomes your specialty wires, which are one-to-one torque and angulated lesions. Started with a Whisper family. Same thing, the whole purpose is a unicore wire up to the tip, and the hydrophilic polymer covers up to the transition core and at the tip, so that you can there is whatever you torque outside, it stays till the tip, so the wire does not prolapse. And that comes in now the extra support and the medium support. We use only Whisper extra support, and the advantage is, this is just like your Boston Scientific Choice PT or PT Graphic and ASAHI Fielder wire. Then basically with the extra support anytime the extra support means that there is a transition in the last 5 to 13 centimeter segment of the wire, extra durability, extra stiffness, so that you can advance your devices. And of course, another wire is the high torque Pilot 50 for the same purpose, which many people like it. We actually haven't used the Pilot 50 in our cath lab. What we have used is the Fielder wire. Fielder is very nice. It's basically the balance of your lubricity, support, and the torque, and advantage is the hydrophilic coating up to the sleeve, and of course the tip being the spring coil, so that whether you should use a whisper versus Fielder remains the choice. But what we found is the Fielder actually provide moderate support. The whisper goes many times but doesn't provide support, and of course now we have the Fielder XT with the 0.009 to find those micro channels, and the FC for the retrograde collaterals. This basically shows about the stiffness, and rapidly move on to the extra support wires. Basically, these are the various high torque extra support with the Mailman, with the Grand Slams and All Star family. The characteristics are shown in these slides, but this is I have created this slide set so that anybody can download. So that any request will come, I'll just tell them go to the website and download these wires. What we really like from the support wire, besides just going with the buddy wire, put two wires side by side, is the ASAHI Grand Slam. Now, Grand Slam become our user friendly compared to the Mailman. Reason why Mailman really provide the better support, but problem is that it really stores a lot of energy and it springs back. So now you have gone to the distal lesion after a lot of struggle. You are taking a balloon out. You are ready to put a stent, and you see your wire back into the guide catheter. So that really the Grand Slam, the Mailman is the final support wire. We don't use the Iron Man. The Grand Slam actually springs back less, so that's what we use in our cath lab. And these are the characteristics of both Iron Man and the Mailman. And this really puts in together of the various support level of the guide wires, that All Star, the Grand Slam, Iron Man, and the Mailman, all to the final extent. And lastly then comes our the stiff wires for the variable stiffness of hydrophilic component, which are basically the Pilot and Choice and Shinobi, and or non-hydrophilic, which are the Crossit, Miracle, and Confienza. And of course, Medtronic has the Persuader. Few people do like those wires, but I haven't seen much use of those wires. Basically, the various characteristics of the wires, I have shown it here. Crossit 100 is a non-polymer coated, non-lubricated, so it's very good for us because it will not perforate, may not succeed, but that is what in our lab I use actually as a first wire before I go to the more stiff wires of the CTO. Now this actually really puts it together, the Abbott's and the ASAHI group of wires for the CTOs, or chronically they call it a Stenosed lesions. Basically is whether it's a straight tip or the taper tip. Taper tip is the Confienza, which is 0.009. So the simple principle is there is an increasing support. You go from Miracle 3 to 12 or Confienza 9 to 12. That is support. But key is that you want to use Confienza for the last few millimeter segment to penetrate. Because if you have long segment occlusion, you want to go with a straight tip of 0.014 wire of the Miracle. And this is the stiffness has been shown here. And now we actually will be present is the Progress family of wires, which will be provide it later. And basically the curved tip, you make it a two curves at the distal as well as the proximal. Now, then wiggle wire, not user friendly. You have to have another wire because it's a very corrugated wire, does not have one-to-one torque. So they basically work on the principle that going through the stent struts or calcific lesions, that it make the stent to go through the main lumen. And then of course to complete the rotablation wires of the floppy as well as extra support shown here. Then quickly go through the support catheters, venture control, we showed it last time, that anytime you want to make angulation, 90% lesion, 90% angle of the venture catheter, which then we have the fine cross of the Terumo microcatheter. This is like a workhorse wire, workhorse catheter in our cath lab. Of course, you can always use a 1.56 or 1.59 millimeter. Then there is another one called Gopher Catheter, extra support, Tornus, kind of a metal balloon, and comes with a 2.1 and 2.6. Then Corsair is the new addition from the Abbott, basically goes through a micro channel, provide much support, and you can see here that many times the torus does not cross while Corsair will go. Why? Because the pointed tip as shown in this illustration. We actually our torus use has gone down significantly, and in tough cases we'll go with the Corsair. Another important addition in this field has been this mother and child guide catheter concept, that you have the guide catheter, but then you can, through the guide catheter, you can advance the sheath onto the distal segment, and that is the guide liner of vascular solution. So that it's 135 centimeter, guide catheters are 100 or 110, so it gives you another 15-20 centimeter, although you can go only 10 or 15 into the vessel and gives you extra support. This is something which we are lacking for many years. They have it in Japan for many years. Now it has come back to USA, and it gives you extra support in many of these tough cases. And lastly, those three important the devices which were approved by the FDA, the front runner, safe strier, and crosser. Most of the people say they are used in peripheries, very little use in the coronaries at this time. We actually have started using some crosser wire of a flow cardia in the coronaries, very limited experience. But I think the whole technique of the CTO recanalization is dependent on the wire choice, gradual escalation, and basically making your landmark with the retrograde injection, and in some cases going with the retrograde recanalization through the collateral channels.
Samin, absolutely excellent presentation. No wonder so many people had requested you to put these slides. Again, we'll see to it that over the next 2 or 3 days in the PDF format, these slides are ready for viewing.
Good. All right, now we can go come back to Anu. Tell us, Anu, what's going on now.
Okay, you have I think one other picture which I took here, which many people don't do that, is using collimators. And what helps by doing collimator is we could not see the entry site in the previous angiogram that we had shown. It's almost like using the IVUS. By moving it to areocranial and using the collimator, what it does, all your X-ray is focused onto one particular area, and we have opened it. And if you see there, Samir, now you are able to see the branches that is nicely splayed out, and at the middle, I think that's where your entry point will be for the LAD, if you can see that.
I think not only does it show exactly the entry point, but also your challenge where the wire is going to keep going to all these branches.
Yep. Yeah, it's going to go into all these branches, and the important thing right now is the wire selection. So we have this fine cross, which is the transit catheter. To reach there, I have used a fielder wire. As you see, it is a coated hydrophilic wire. Once we reach there, and what the teaching is that you use any kind of the first line wires, which are usually the miracle wires, which is 3, 6, and 12, and the numbers are given based on the tip load, how heavy it is, and that will help you to drill through the length of the CTO, and usually use the other wires, which is the Confianza, which has better penetration, and more important, with the Confianza wire, your tip is tapered. Tip is tapered, and that will help you to do the final penetration. But here we may have to change our strategy, since we have to make a hole into the LAD just to get a channel. We may have to use the Confianza first, just to get into the lumen. And I think Dr. Sharma did mention about the progress wires. It is a progress wire is a combination between the fielder, the miracle, and the Confianza, and based on the weight of the tip, they have different numbers: 40, 80, 120, 140, and 200. And the tip varies anywhere between 0.01 to 0.009. The main difference between the progress versus the Confianza is that this is a hydrophobic tip. Since it's hydrophobic, your tactile sensation is preserved, whereas your Confianza, it is tapered and it is hydrophilic. So we just, what we use in our Indian language, what we say is our final astra. If you have to go anywhere, you can just use a Confianza, and you know it will just make a channel, and many times you will be in the area that you don't want to be. But here, once we reach there, if you see it.
Now, just to give the word about the collimator, and this is the board question. that collimator does not decrease the dose for the patient. It actually increases the clarity, largely because it takes away that the out of field scatter, so that pinch cushion effect. But it actually increases the dose to the patient, but it decreases the dose to the operator, and there is a less scatter background radiation. So the people in the room will get less radiation. But if you think about from the patient perspective, the collimator gives rise to a more radiation to the patient.
Anu, those were further useful tips. Now you have
as you see, this is exactly what this is what I have is a fielder, and what we predicted is same. It's going to every branch except the
which one is this?
No, this is a regular fielder, not a fielder XT.
Yeah,
so I'm just going to change it to the Confianza.
Okay.
So exactly the escalation wire strategy which Samin had described, you're going to generally follow that with some exceptions.
Exceptions, yeah. This is an exception, and I just want to show you how we make the curve. You need a very small curve, and the usual recommendation is you go through your needle wire introducer, and at the tip you make it, but we can also make it just at the tip here, a very short.
Samin, some questions have already started coming up. How about cardiac bypass surgery? When would you consider for this patient, including off-pump lima to the LAD?
Yeah, well, I would say that if we are unsuccessful, this should be a good, because patient is quite young, very active, and if we cannot succeed, and succeed basically means the 2 trips. I always say that once you decide for the CTO, unless you have really caused the artery in pieces or bad perforation, and so you always tell the patient that even if he is unsuccessful first time, we'll bring you back for part 2, because the success rate with the 1 and 2 is combined over 90+%. So
when would you bring the patient back for the second trip?
Usually anywhere between 4 to 8 weeks, based on the how much damage or what was the limitation when we did the intervention. So if a routine case, we book it about 6 weeks. And the second try, second try is very successful many times, because we know exactly, and many times you have created those all dissected lesions, the channels, they actually heal by the time patient comes back, and may have a slight lumen.
Bring the monitor.
So Anu, how do you decide at which point you'll advance the fine cross a little further?
I'm probably going to advance the fine cross now. I just cannot get the wire is just moving so much, I cannot get it to anchor at a point. Once I know it's anchored, then I would want to advance the fine cross, and same, it's a one-person job. You cannot ask your assistant to advance.
Samin, another question, did you consider doing some platelet function studies in this
Yeah,
patient?
we already expected that, and we did check the Plavix. She's on Plavix, and she is 69% inhibited.
Yeah, right. And that's a very good point. Since the black box warning, we actually trying to start in a limited fashion that some high-risk patients try to use the platelet assay for the genetic polymorphism of a P2Y12.
If you see the my movement, Samir.
Yes, I noticed that, and you may be.
So that until I knew that it had to anchor, and once it anchored, it's already engaged.
No, it's not engaged. Right came out right there.
So at this point, you'll take bilateral.
Yeah.
Okay. You need to reseat your.
Yeah. Therefore, what we are doing it in about 25, actually almost 30% of patients who are suitable. That means the young person, more than 60 kilo, less than 75 years of age, diabetic multivessel disease, acute coronary syndrome, multiple stents. Those patients, we are starting them on as a de novo, as a prasugrowth. Now, many patients who are coming already on Plavix and they are still high risk category, then we'll test them. We'll test them for the Plavix sensitivity, and if it is less than 30% or 40%, we'll switch to the prasugrowth in the cath lab. The routine genetic testing, we are just trying to come up with a protocol that some patients will start doing it soon, and the results will be, I know that there is a lot of ethnic variation, the disease variation, a lot has been written in the literature. Recent yesterday announcement at the heart.org by Eric Topol and the team that at the Scripps Clinic, that this genetic testing is becoming routine. that they are testing every patient for the polymorphism, because those are the patients who can develop problem later on. So that this has not been our experience. Reason being is it's a cost involved. It's about 150 to 200, and there has been some of the companies have already made the point that they will not pay insurance companies, so the patient will be hit with the bill. So that how we are going to do at Sinai, I have a meeting today actually at 10:30 after our morning webcast, that how we will be using, in which group of patients will do the genetic testing. And I think it's a good way to basically manage our patients, but I just want to tell everybody that the event rates are so low. We are talking about event rate of 1%, and therefore does it justify to test your another 100 to see one event, and can by genetic testing would you prevent that event? It still need to be seen. It's not there.
Well, scientifically that's always an issue. I can tell you the HMO answer.
Yeah, yep, that's it. They actually HMO has already declared that they are not going to pay for it.
Anu, what would you predict? Are you in a septal or in the?
I think I'm in a septal.
Yeah, that's
but,
what I thought.
Probably is yeah.
You want to get a Lima guide?
No.
You need
See
something.
now, if you, I was watching Samin, you're trying to persist with
Okay.
getting the right
Yeah.
picture there, which I think will be crucial. Here you go.
Good. Go to our earlier view.
So now this should demonstrate us whether you are in a septal or in the true lumen.
33.
Yeah,
34,
them too.
right?
Yeah.
We go to same 33, 34.
Samin, more questions have started coming up. When would you not do a bilateral cannulation?
Well, I would say the same, that if the ipsilateral, particularly the left side, in every right case you are planning, even if you have bridge collaterals, you should do it.
No, don't just give some dye.
Yeah, that's what I'm saying. Good. Oh, sorry. Too different.
Then
We
have
need to
this-
give. One second. No. There are some
More
difference now.
Yeah, you are.
Yeah.
It looks like it made through the right this thing, and then
Pull back.
might have to even come back a little with
Quite a
the
bit. With the even
support catheter.
Exactly, with a fine cross. Come back quite a bit.
Now, at this point, would you consider switching a wire to a different one, or persist with this to
Persist,
help you?
I think.
Yeah. Okay.
Okay. Want to give contralateral?
Mm-hmm.
That looks to be no.
No.
Did you went to the confluence directly?
Mm.
The same, the tactile sensation is the whole case in this. And anytime you start seeing the PVCs, that it majority of the time, I know
subintimal.
sometimes it's a fallacy, but majority of the time it means that you are not in the vessel.
Right.
Yeah. To me, I think you need a little stiffer tip here.
Mm.
No. We should see it in some different view because we're not going through the same line.
That
Go back to
also,
the same.
Huh? You want confluence the 12? Now we are already. I would say that I would go with the miracle first.
that is looking, well, it can be very deceptive, but it tended to take a slightly different course there. Samin, another question for you. What percentage of cases are antegrade for the total occlusions?
Yeah, we actually in our cath lab, I would say 98%. Want to take a picture? Let's take
Some
a
dies, so you know where we are. So
Yeah.
don't have to keep taking picture.
No, I don't think it's in there.
You can go
Yeah.
with the.
The majority of are, is the same. With the second trip, as I mentioned, that, basically the retrograde injection, maybe we have not mastered it yet, takes a lot of time. Therefore, we always still believe in the antegrade injection, and that has been a very successful. As you know, that overall, that presence of one total occlusion on the angiography is shown in almost 25 to 28% of angiography. but but the PCI of the CTO makes only about 10% of our intervention. And that's kind of a national figure that remains constant despite the newer techniques. The recent data of the ACC-NCDR, which they presented last year in this year in March, ACC, that is still only 12% of our PCIs involved total occlusion, largely because that now even more restriction, even if you got better, but which patient should get the CTO PCI based on the revascularization criteria is quite difficult in the sense that the patient has to need it, showing ischemia. Not that you found a totally occluded RCA when you did patient came with acute coronary syndrome of the LAD, and we were bringing them routinely to do the CTO recanalization. So that it still remains around 10 to 12% of the latest of the ACC-NCDR, and but total occlusion presence is almost in 1/4 plus of our angiograms.
Anu, bivalirudin used here?
Yeah.
In the wire. You have to come back right from the beginning.
I think
wire.
so.
Yeah. So which wire you want to start with? I would go with the Miracle because this is the long segment.
No, give the 12. 12, yeah.
So which would then be exactly like what you had shown in one of your slides. The longer segment is
that you start with a little bit because what has been shown that by the time you go through the half of the lesion, 5-10 millimeter, the confiangia being such a small tip of 0.009 will lose its strength. Therefore, just keep it for a short segment. Although I know that Anu is quite good with this confiangia wire, so that she's going to try now.
I mean, two more very interesting questions. How much time will you not exceed for a CTO, and how much dye will you not exceed?
Right. I think this is all quite relative, but going with your the fluoro, your overall time of 100 the minute is usual time allocated, in my opinion. That once you go beyond that, basically it's a time to quit and bring the patient back for the part 2.
And 300 cc dye. And
the dye, if we go with that total allowable contrast, which is the 5 ml per kilogram, you usually get to that 300 and so.
You know, there's a funny story how the 100 minute was chosen, because it takes the Japanese 100 minutes to make a Toyota.
That's it. Not looking good.
We can go with the...
Is there a little dye stain there, or?
Yeah, which is all right. I mean, as long as you keep it low. Now, this question will come once you have this kind of diastasis and patient is on contralateral side.
No, LAD.
That once you have what will happen once you already is this here. So this kind of injection, you need to be very careful, and this is where the issue comes with this confiangia wires. I think what we should do here, go with a little simpler one, get a Fielder XT,
or even a regular Fielder.
Yeah, Fielder.
So at this point here with this angiogram, would you turn off the bivalirudin?
Yeah.
No.
I mean, as long as it's not beyond very high, so that it's okay to stop it for a few minutes while you are working on it, knowing that it's a CTO, that small wire perforation heals quite well, less of an issue. But you always have to be careful. We used to be worried about these things. I can tell you 3 years ago when we saw this, first thing will be that we are out.
I can tell you, Samin, that the majority of the people would do exactly that. You know, they see this and realize that, look, this is beyond their comfort level, which I think is not a bad idea for most people who don't do enough of these.
Yes.
Some dye.
Okay. I think you need to get a better view.
That view was good.
Yeah.
The one we had.
Okay, now we'll try to see a little better in terms of which view should we be going in. They did give you some indication to be able to get through. See that it's a good vessel. Now, while we are letting heal.
33, 34.
Yeah, that's where we are.
No, we are in a different view now. You have the fielder XT?
Yeah, well, let me try that. Yeah, I made it. Just 1 second. Yeah. So where are we now?
Same view.
Yeah. Good. That's good.
Okay, that's
Now the patient, I'm sure,
is fine.
no chest pain?
No, nothing.
Okay.
The patient is doing good. Electrocardiogram is fine, and no PVCs or so.
And the blood pressure is good.
Yep, and the hemodynamics wise, patient is fine. So what I'm trying to do now is that going with that fielder XT 0.010, trying to see those micro channel concept. It does work many times, and that actually at least traumatic of all. So that will give us a time to this little perf, micro perf to heal also. So that, but now Anu, you should decide your new strategy that which other wire you want. I think you need to go to a less aggressive wire. Now, one thing I always say, once you start seeing this this cloud, try to go with the less aggressive wires. You probably will have a better chance and successful with a less aggressive wire versus more aggressive.
It's the same channel.
Yeah, we'll see. Yeah, it's about the same channel. So what we are going to do now is this probably is the total there. So now give the injection of the.
RC.
Yeah, just 1 second. Yeah. Inject.
You know, the view is so deceptive because the.
You have to go forward. Now with the.
You
probably came out.
RC injection.
We have this. Yeah, probably that. No, same thing.
It's the same thing. That at this level.
See, there it entered into a slightly different.
Yeah, no, but I think there is this is the second level injection.
No. Same.
Yeah. See, it's at this level is the one which we need to make it now.
No. Right there.
Okay. Now decide which wire and make a curve onto your other wire.
We never used the confluence of 12, right?
No, you use the confluence of 12. That's the
You
confluence
mean the
of 12.
200 progress. No, but I don't think I.
But now it's the same thing that it needs a. I'm going to take this one out and make it a little new curve.
Right.
Wait 1 second.
A little more curve, no?
Little more curve, exactly. Little bigger curve, and try to see if we can get to the distal lumen. If not, then tell us what's your strategy. What wire you have now?
The progress.
And which is strength? Progress?
Yeah, the progress 200.
Anu, why did you choose that as the next wire?
No, it's just the hydrophobic tip, which right now you need to do a re-entry into the LAD at that level. See, we're exactly at that level.
Yeah, this is the total occlusion segment. Now, any time which I say that in total occlusion, you're going very easy, I can tell you are subintimal.
Yeah.
In the meantime, if you look at it, the radio contrast, this thing has diminished in size. Yeah. So that's
reassuring.
It's very reassuring. Yes, I can tell you because.
We'll start it.
And then what we'll do is we'll restart the Angiomax.
Right.
And the simple and this is what I got a few. You saw the letter to the editor in the our CCI. Basically, but we made it very clear that this is what we are talking about, wire perf. This, although we use that in our cath lab, will die. If not, I'm going to come out. Yeah.
Come out.
That we are talking about the wire perforations. Now, it does not reflect that it has done anything different if you have a big perforation of the stent or anything, but it's for wire perforation. The Angiomax actually, in my opinion, working as a boon rather than a disguise. Little die. Boon in disguise that the many times this just stops and remain very good. Okay, though I'm taken this fielder XT out. The concept of our micro channels is bye-bye. Didn't work. I know that a lot of people think about this micro channels are there, but I have yet to find in majority of those patients. Where they are, I think they exist histopathologically, but not clinically. Has been a very, very important issue.
Dim the lights.
Okay, now this is a progress wire. We want progress wire to make some progress.
You don't think that the fine cross is probably, oh no, it's okay, that's fine. For a moment I thought it's, you've advanced it.
Yeah.
Of course, you are not following any ACTs for the bivalirudin before you.
I mean, we do it also because some of the cases, I can tell you where we have the cases where there was a thrombus. It was usually that the bivalirudin never went in the patient's body.
Something happened with the last injection. You have a more of a dye hang there.
Keep the bivalirudin off, Angiomax off for the time being, and we can just
some dye in the RCA where we are.
look. RCA injected. Same thing, that the key is that the contralateral really helps to go forward or with the prevent any significant passage of the subintimal tract.
Some dye, RCA.
The way the wire movement is, it's
No good, you're saying?
yeah, good. This may no. You have to pull back a little more still.
Some dye in the RCA. No.
Yeah, totally different channel.
Right.
It looked like a very large vessel, and I think it's so deceptive that when we started, that will be a very short segment of the lesion. But the problem is that lesion, there was no channel, and once the entry point is not there, to me that is the biggest issue with these with the CTOs. You don't see the entry point, then it's a lot of guessing game.
Well,
Maybe
also it was slightly foreshortened in that some of the earlier views we took. Samin, you think for people trying to do a lot of total occlusions, is a trip to Japan absolutely mandatory, as it looks to be being practiced these days? Just about everybody is headed on Japan Airlines.
Right? Give me a new conference.
Yeah, well, I would say that the basically is, yes, before you embark on, whether you bring the physician here or you go to Japan is the choice, but you need to do learn with these devices, the wires, the combination of the sheath and the contralateral, the retrograde, the parallel technique, the IVUS. Of course, that's one of the big, although we don't use IVUS guided CTO recanalization till we have the forward-looking IVUS of the which Volcano is working on. But all these things, I think, to become master in this technique, that you need to do a little more than what, because point is, when you are a fellow, you are rarely.
Injection, please.
Well, I've always had a feeling that the big difference is the Japanese have a far higher rate of doing retrogrades.
Yeah. Yeah, actually, you know what, the retrograde, the latest paper in CCI, cardio in circulation intervention, from Japan, that basically still remain about like the cases where they try, it's about 70-72% success rate.
Right.
And the angulation of the retrograde channel is a very important region where they are unsuccessful. They of course will usually identify, but once there is a entry angle of the retrograde vessel, that's one of the important issue in terms of their failure. Now in this particular case, the branch point, as you can see here, retrograde may not be a great choice here,
right.
largely because see the septal just goes there, and the proximally the total occlusion, and it's at the branch point. So if you go with that Rathod's paper from Japan in our circulation intervention about 3 months ago, this will be another very unfavorable lesion morphology for the retrograde because of the angulation of the septal, because that septal is the one we are going to use it for this purpose. Yeah, let's see those small. We have checked the ACT or no?
No.
Check the ACT.
Okay, some die now.
Yeah. So just want to make sure that it's remain less than, although you are not going to do anything different anyway, but keep it less than 300 and so.
Injection RCA now.
No.
Somehow it's giving a different. LED injection.
You hold the RCA, I'll do the LED.
Samina, you're doing some CT angios before attempting some.
Yeah, that's another very good point. Actually, many of these labs nowadays, they are equipped with your CT angio pictures coming back at the into the lab, so that you have a little landmark, landmark into it. But we have not been very good at it yet, and we don't have the system, so that we do not use the CT angio. I think that will require a different level of learning and teaching, and but yes, as you mentioned, that this actually has been also presented by our Japanese colleague, and they actually follow that very religiously, that the CT angio making the landmark, and then you are able to see that which way to go, what tortuosity, what is the calcification, and so on and so forth has been the issue. Want to see it?
Some die in the right
side.
There's a different path there.
Yeah. Now let's take a good cine. Only way will be the cine. There is no PVCs. If you want to, let's go to this view 1 second. 33, 31.
And
I'll
the
tell you which.
distal tip still feels very free.
Yeah. One second. Which one was? Sorry,
No.
4 and 34. Good. So let's take a picture. No?
Why we don't see the? Because I think we have the.
You'll inject the RCA. Yeah. It's a tough call.
Very tough call.
The wire seems to have gone.
It's in a different path, I can
Yeah.
definitely see.
Yeah. Okay, let's try to see if we can advance it without much resistance.
Yeah, it is going easy. Oh, you mean? Oh. You have to inject a little bit distally, right?
Okay. Now what I usually do is advance your catheter, and then if you have it, you'll be able to see part of it.
That's right.
Yeah, we noticed Anu do that and went quite freely. At what stage will you consider putting in a small balloon there?
No. You don't want to inject through this one?
You want to do it? Okay, go. There's no other choice here. No, we have it.
We have.
We have it. That's fine. Okay. Take this wire out. No, 1 second. Have you brought it further? 1 second.
No, I have not brought it further. Yeah, you have to go further.
Okay. Good?
Yeah, good.
Okay. Take this wire out. No, that's the die. One second. Take the. Now, once you're taking it out, either put it under the water or it has to be saline because you'll be injecting. Usually, you can change the wires without any problem, but in this case, because you'll be injecting, you need to be airtight from that point of view.
Just little die.
A little bit in the pericardium, I think.
Yeah.
No.
Not sure, huh?
Yeah. No. No good.
Okay.
Yeah. So we're going to stop it here, bring it back,
Now let's
and
try with the whisper.
start
Give me
again.
the whisper.
yeah, whisper wire. Maybe we can try that. I know there are a few minutes. This is always a challenge, but we had to go with the challenge and try these tough cases.
So, I mean, these
What are you worried
chronic
about?
total occlusions are always a
Then
challenge.
disconnect and take it out from there. Huh? Take it out from there, disconnect and take it out from there. Why are you taking it so far? Disconnect there and take your whatever you need. Yeah.
Some die. Some
Which one?
EKG changes now.
Yeah. Okay. Yeah. Connect. Yeah, we need to engage again.
Not the right.
Yeah.
I need the.
Yeah. We need to do pericardial synthesis.
No need. Why?
Okay. Yeah, we need to. I think this is just it's the same thing. This kind of case, I think we should wait a little while, and maybe about an hour or so, let our micro channels which we have created, or micro new channels, iatrogenic micro channels which have been created, that we just let them heal, let the perforation seal, the microperf, and then restart in few hours later.
So
Patient is fine.
You would take the patient off, hold him in the cath lab, and
Well, no, usually this kind of case, we know that we have very limited cases for the CTOs, so that we keep those kind of cases up to 2 to 3 hours in the lab, and this kind of patient, you probably will leave it for about an hour on the table.
Right.
And basically it's the same, that it's once you wash this out, I think we need to go with the retrograde injection.
yeah, I've always found CTOs very tricky for live cases because time does pass fast when you're trying to do this extremely diligently and carefully. So, I mean, we have come to the end of our transmission time. What would you suggest from here? How do you?
Well, I would just say that, doing a CTOs are issue basically, and then we just had to go very carefully, and the purpose has been that we last month also we had a little suboptimal result of that CTO. That patient will be coming next month. This patient we still will try a little more, leave it on the table, and for the time being the angiomax has been stopped, and we just have to see how patient does. Maybe in about half to 1 hour, when these microchannels, iatrogenic microchannels will heal up, that will restart, we'll give it a try once again.
Anu, take me through the strategy. Let's say in a few hours, how would you proceed?
If everything has healed and no, I think we're trying getting into the. There's a question. Yeah, I know.
Yep.
Means get into the lumen at that time would be by using this glide wires, because we have created micro channels now. That's what I'm trying now.
Yep.
Usually what happens when we let the things heal and we come back, it's like almost again a new artery. But this is going back to the same small.
And patient is fine. We have spoken to the patient. There is no chest pain. Good blood pressure. Actually, she is hypertensive.
So how would you decide bringing the patient back in 2 hours versus 4 weeks?
No, not 2 hours means we don't take the patient off the table.
Right,
She'll stay
stays there. Okay.
Yeah.
Same. I mean, if
but if there is a hemodynamic compromise, then you
obviously
stop the case.
Right.
But otherwise, you still want to try it once again. Still try to give it a try. See, it comes down.
Right.
But it's still not to the true lumen. Now, this kind of case actually will be very good to try in a few weeks, because we know all these channels and all this will heal nicely. See, we are still parallel. I think with that note, if it's okay from your side, we can conclude today's this live webcast. Quite a bit of theory, a lot of practical tips, and the next month, there is a little change in date, and we actually have a very good case of impala with the rotational atherectomy of the LAD via the left internal memory. So it will be a very calcific LAD with the lima, and patient with the EF of 28%, and we try to do a rota with the impala device for LV protection.
That would be on June the 8th, so that you can have time for your live course in a few weeks' time?
Yes.
Excellent. We will see you then. Now again, the fact that we are cutting off transmission, you are of course proceeding with the procedure. I wish you luck, and of course we'll try to provide you a follow-up. We will see you back on June the 8th, and thank you all for watching, and the slides which Dr. Sharma presented will be placed on in a PDF format. Thank you once again, Samin. Thank you to you and your team.
Thank you. Thank you.